One of the things that I love about Penny LeGate, my favorite people in the world are people who have endured hardship and loss, and not only endure it, but rise above it, and then do a lot to change the world for the better. And we have some amazing examples all around us, but I think Penny is a perfect example of someone who really went through a terrible thing with the loss of her daughter, but has done incredible work after that event. She's been instrumental in getting Narcan in the hands of police officers in Seattle. I don't know how many lives our panel will tell us. Lives have been saved because police officers have been able to give that drug to reverse heroin overdoses. So our panel today will be led by Penny. We also have our member, Dr. Molly Carney, who is Executive Director of Evergreen Treatment Services. You know her well, and Caleb Banta-Green with the University of Washington. I think what I'll do is I'll turn it over to you first as Penny comes to join us. So let's start with you, Molly, and we'll begin from there. Caleb? Molly, good to have you.
Sure. Hi, everyone. Thank you for having us. We're happy to speak with you today about this really important topic. I am the Executive Director of Evergreen Treatment Services. Many of you know that we offer medication-assisted treatment for adults with opioid use disorders. So most people at the point that they come to our program are active heroin users. And the medication that we offer them helps to stabilize their brain condition and help them move into recovery. So we operate 4 clinics across Western Washington. Our headquarters is down on Airport Way, just south of the International District. And any of you are welcome to come for a tour. I highly recommend it. And I mean that sincerely. I'd be happy to give any of you a tour. We have, again, about 3,000 people in treatment across those 4 clinics in Western Washington. And we also operate a street-based case management and outreach team from the Belltown neighborhood. They're called our REACH team. So they are actively engaged in people who are currently homeless with substance use disorders, and many of whom have mental illness conditions as well. So with that, I will pass it to Caleb.
Is this one on? Great. I'm Caleb Banta-Green. I'm a principal research scientist at the University of Washington's Alcohol and Drug Abuse Institute. And as we'll talk about in a moment, I am a researcher, but an extremely applied researcher. About 80% of my work now is supporting people in implementing evidence-based interventions, because we know what to do. People just need help doing it. And as we'll talk about, really switching from being very fearful of this topic to moving to being fearless, because we have a lot that we can do. So I'm very excited to be here. Thank you.
So hi everyone, I'm Penny LeGate, and honorary Rotarian of many clubs, happy to be here. Traveled with Rotarians all over the world to immunize against polio, and have spoken a lot on that topic, but here today we'll be talking about something else that's even more personal to me, which is the opioid epidemic. This is a great opportunity to be here, and I want to thank you and to Hamilton and Mark for having us here today, because hopefully you will leave with a little better understanding, because we hear about the opioid crisis almost daily in the newspaper. And if you haven't been personally touched by the epidemic or this disease, then you will probably learn a lot, hopefully, today. So as you know, we have somebody here from the treatment part of it. We have somebody here from the research part of it. And my job here is to really just talk about the personal side of the opioid crisis. We're going to take a look just quickly at this word epidemic, because you've heard it over and over. And it's like we hear about Ebola epidemics and flu epidemics. And we use the word epidemic because it truly is an epidemic in our country, not just here in our state, but all over the country. And in 2015, for the first time, deaths surpassed those killed in the Vietnam War. Drug overdoses, huge, huge numbers we're talking about here. And then last year, or 2 years ago rather, it exceeded car accidents as the leading cause of death for teenagers. This is kind of what we think of when we think of somebody who's maybe a drug user or on the streets, down and out. There's a lot of judgment about people who look like this. We certainly have a lot of them now in our community. And as you know, daily, the mayor and other people in the city are struggling to try to deal with this crisis. This is somebody's child. Growing up in western Nebraska, Dad was a president of Rotary Club in Ogallala. I had no idea what drug use looked like. Our wild ideas of partying were going to kegers out in the cornfields. We didn't have things like heroin and cocaine and ecstasy and other drugs. And this was my image up until about 7 or 8 years ago of what a heroin addict looks like. But this is also what somebody who has substance use disorder looks like. This is my daughter, Mara. And she died almost exactly 6 years ago of a heroin overdose in my home. And I would have judged people before. How come a parent could let a child be a drug addict? How could they let them be a user? How come they're not sitting on them, watching them, guiding them? Well, you know what? A lot of kids who end up dying of overdoses come from great homes. Yes, many of them are traumatized, it's true, by abuse, by homelessness, by rejection. But Mara grew up in a perfect little family. She loved her pets. She was a beautiful ballet dancer. This little girl lacked for nothing in terms of opportunity. She was a fast pitch player, select fastball, could throw the ball 65 miles an hour when she was just 12 years old. Extremely smart, funny, talented, and troubled. You know, we talked earlier today about Randy Revelle and his mental health issues. I'll bet there's not a person in this room that doesn't know somebody who's dealing with some sort of behavior or mental health issue, and there's no shame in that. And Mara had lots of mental health issues that led to her drug use. Depression, anxiety, ADHD. She had an eating disorder. So she was a complicated child, despite our best intentions to raise her in the most loving, supportive environment possible, and to get her to all the best doctors and psychiatrists we could get her to. So we never know what demons are inside somebody else. Mara used to always say to me, "Mom, I don't know why I'm like this. Why can't I just be like a normal kid and be happy and go to the prom and do these kinds of things?" And she always used to say to me, she was heavily judged for her struggles. And I just want to share with you something she always said to me. She would say, "Mom, we're not throwaway people. We're not throwaway people. We're not the losers and the junkies and the derelicts. We're people who are struggling with a real disease." So now, I'd like to introduce you to my dear friend Caleb Banta-Green. You know, he's with the University of Washington, the Alcohol and Drug Institute. And I first heard Caleb on the radio many years ago, right after Mara died, and I was struggling to find his name. He was talking on Como radio, I think, and I said, who is that man who can talk so eloquently and compassionately about a disease that usually just has a lot of statistics around it, that it's easy to just like get deadened by the sheer numbers. But this is a man who really puts the compassionate spin and interpretation of what's going on out there. So, Caleb.
Two hands, I can do it. I'm very happy to be here with you. Thank you for your attention and listening on this topic. As I said, this is a frustrating and scary topic for everybody involved, and I think that's really important to understand. I hear the same frustration from emergency room physicians at Harborview as I hear from law enforcement. It's just a frustrating thing. It's frustrating in our community, it's frustrating within families, it's frustrating to the person who has opiate use disorder or substance use disorder. But we know a lot about this, and there are a number of things that we can do, and I want to give you kind of the ABCs of what is opiate use disorder, how is it treated, and the impacts of treatment tell you about an example of a novel program we're doing here, and I think maybe give it back to Molly and maybe flesh out a little bit more any of the holes that I've left. So, and I want to just share with you, it's actually really important because I'm going to talk about treatment medications. So in my line of work as a researcher, it's important for me to say that I do not have conflicts of interest. I do not take money from pharmaceutical companies. My funding is from federal grants, state contracts, and private foundations, so you know that. So this is probably the number one question I get, and I think it's important to understand how does a person go from using pills to shooting heroin, because it doesn't make any sense, except that it does. Each step does make sense. And so the first component is the person has to try it, and trying it is about two things. It's about access, so actually having access, and in this case it's about prescription opiate medications. Just so you know, in Washington State, we have about 100 million daily doses of opioids sold in Washington State every year. There's plenty of opioids out there. So the access is there, and it's increased dramatically. So what can you do about that is you can not take them into your home in the first place. You can get rid of them as soon as you don't need them anymore. The other big piece about trying it is motivation. And that's really complicated, and I can't pretend that it's a simple thing. We hear certainly about peer pressure and all of those things. There's genetic predisposition, there's personality types, and there also is really importantly for many people a history of trauma, whether it's physical or emotional trauma. All of those things can really lead a person to want to try opioids, to try to get some escape of some sort. And then you have to be among that group of people who kind of likes them. And about a quarter to a third of people who try heroin or use a pharmaceutical drug in a partying context ends up being addicted to them. So it's really important that set and setting matters. It's not a third of people who use opiates prescribed to them for back pain. It's in the context of using to get high. So that's very important to understand that. And some people like them and some don't. Many people feel sedated and nauseated and don't feel good on opioids, and some people feel energized. And almost the most concerning thing you can hear is a person saying they feel normal, and feeling normal for the first time in their life. So imagine that's your reaction, that you felt abnormal, and all of a sudden you found the thing that makes you feel normal. So if you like it, guess what you're going to do? You're going to keep using it. And you're going to use more and more and more. And the reason you're going to use more is that opioids create something called tolerance. You need more to get the same effect over time. And if you're trying to get that high or that euphoric feeling, taking it by mouth, taking a pill is going to be very inefficient, and you're going to move to using it another way, snorting it or smoking it or injecting the drug. And at that point, when you've moved on to smoking or injecting, you have a choice to make because you've probably burnt a lot of bridges and you've probably emptied out your bank account and maybe somebody else's bank account as well. On the left side, you can see what an oxycodone molecule looks like. It was made in a laboratory purposely to look like the substance on the right, which is the main metabolite of heroin, which is morphine. The brain can't distinguish between them. Unless you're a chemist, you probably can't distinguish between them, but your pocketbook can. It's much easier to access illicit drugs, and they're much cheaper. So that's why it's logical for a person to switch to illicit drugs at that point. So another way to look at this, I'm all about pictures, and hopefully my hope is that one of these pictures is the right one for you, because this is a multi-part issue. It's somewhat complex, but it's totally digestible, I believe, if you break it into its pieces. So another way to look at this is a person has to use opioids at the front end, obviously, and some people then will, if they continue to use them, will become opioid dependent. Which really important to understand, the main thing I want you to take away from today is this difference between physical dependence on opioids, a normal biological reaction. We will all have this reaction. Some people move into use disorder, or what we think of as addiction. So opioid use disorder or addiction has three pieces. There's the biological part, there's physical dependence, which we talked a little bit about. There is psychological dysfunction, sort of thinking problems, craving. There's nothing else more important in your life. Really, really important. It's a change in salience. It's a change in what's most important to me is a delicious grilled salmon and maybe some chocolate, which is pretty high on my list, or caring for my kids, to moving heroin to the top. And it's biological. You can look at brain scans and see the basis for that, the change in the brain. And then within that, of course, if you're using all the time, you're thinking about it, it's the most important thing in your life, of course that's going to cause social dysfunction. I can't be a good kid or a parent or employee or neighbor if all I'm doing my whole life is revolved around substance use disorder. So there's physical dependence on opioids, and there's opioid use disorder, and there's chaos. There are several different paths out of opioid use disorder, and I want to briefly describe what they are. So, it's a little bit complicated, and I'm going to end with the one that Molly's going to elaborate on. At the bottom, actually on the right side, I'll talk about using social support and counseling to sort of get out of this pathway of substance use disorder. And social support and counseling can be really, really valuable for many, many people. They're not the right thing for everybody. It's important to understand that. Not everybody needs the, social support and counseling. Many people do. The challenge with using just social support and counseling is you're addicted to opioids and you're no longer using opioids, which means you have no tolerance on opioids if you stop using. Your chance of relapse and overdose is incredibly high if you're just using social support and counseling. Your chance of dying is twice as high as if you're on medications. So it is a pathway that some people choose, but we want to make sure it's a choice. We want to make sure people are making an informed decision and understand these other pathways as well. The bottom pathway is using a medication called naltrexone. Naltrexone binds to opiate receptors and just blocks it. It's a pure opiate blocker. It's taken by injection and it lasts a month. With that medication, what we're finding is there's emerging research that some groups of folks, people coming out of inpatient or detox, that some people can do well on it. A lot of people don't want to be on it. A lot of people can't start using it. Many people don't feel normal on it. However, there are some folks who do like it. I've worked a lot with people coming out of the prison system, and we're doing some work statewide right now. About 10% of people moving out of that system are interested in this medication. So it's an important option. It's important to understand that it doesn't have as much evidence. We don't know all the best ways to use it and support people continuing to use it. And the issue is you're opiate blocked, which people really like. It sounds great. It sounds like medically enforced abstinence is what it sounds like. But I mentioned that some people feel normal on opioids. If you're one of those people and you're taking an opioid blocker, there's a chance you're not going to feel right. So you need to know about other options as well. So another pathway is the one coming out of the top are two opioid medications. They connect to opioid receptors, they bind to them, and they turn them on either part way or all the way. And in those medications, you end up still physically dependent on opioids. You're still physically dependent on opioids, but if you don't have the psychological and social dysfunction, you are outside of the disorder and chaos of addiction. And that's what's fundamentally important for people to understand, is that you can be in recovery and be on medications. And most people don't understand that. I gave a talk at Recovery Cafe a few years ago, and a gentleman came up to me afterwards, and he had been on and off medications at least 10 times in his life. He would get on medications when things were going badly. He'd be doing great. He's like, I don't want to live this life. I don't want to see myself as an addict anymore. He'd get off the medications, and he'd relapse within a couple of days or weeks. And he'd gone through that cycle 10 times. And he had never heard those words, you can be on medications and be in recovery. And again, these medications, buprenorphine and methadone, reduce mortality by at least 50%. When France liberalized prescribing of buprenorphine as a medication, their overdose mortality rate dropped 79%. So we have the opportunity to really rethink how we provide care. So as I mentioned, medications have the strongest evidence base, and they must be offered. We can't mandate that people be on them, but it really would be medical malpractice to not offer people and inform them about the most evidence-based treatments. These two medications, buprenorphine and methadone, reduce mortality by about 50% at least. They dramatically reduce criminal activity and recidivism, of course. That's quite obvious. They improve the quality of life. People come back to themselves. You get that person back. Not just are they not dead and not using, but your loved one actually reemerges as that person you knew and loved. And they're highly cost-effective. They're incredibly cost-effective by every metric. And naltrexone, as I mentioned, has this emerging effectiveness data, and it seems like it works well for some folks coming out of inpatient treatment or incarceration. And what we also know is that care coordination is really an essential component, which Molly can speak to, and counseling can be invaluable for many people, not everyone, and social supports are also really important for folks to have access to. So I think I just want to wrap up, give you these websites so you know about them, and I want to share with you one last thing we've been working on for 2.5 years in the Seattle area, and that is access to treatment medications when and where people actually want them. So one of the things I do, I like to joke that my job as a researcher is to document the obvious. And I do that by asking people what they want, and then I try to get it for them, even if they're people who use drugs. And so we ask people who inject heroin, would you like to stop or reduce your use? 78% of people say yes. We ask them what services they would want if they're readily available. The number one answer, 70% say treatment medications. So what did we build? We built a program. I'm down here at 4th and Blanchard at the Public Health Clinic, and there are several other programs where people can show up, they can see a nurse, they can get started on treatment medications that day, and they keep coming back every 3 days or so, and they can pick up medications, and over time they can move on to a bi-monthly or monthly prescription. And all we're doing is offering them treatment medications, making them free and readily available to them, and then offering them really good counseling and social supports. And that program, we've enrolled over 150 people in that program. It was initially full at 12 weeks. People started lining up 2 hours early to get on treatment medications. Not the newest fancy Vente coffee roast, treatment medications. So if you build it, they will come. And that clinic has enrolled 83% homeless folks. So we're getting to the right folks, and we're able to address getting them stable, helping reduce their chance of dying, getting infectious diseases, and ultimately helping them return to their life. And then we're also partnering, that program and other programs are partnering with places like Evergreen Treatment Services to get people into a more long-term care model. That's really an emergency public health care model, trying to keep people alive for these next weeks and months, but we're really looking at how to help people manage their condition for the rest of their life. And that's where we really turn to an organization like Evergreen Treatment Services. So I'll wrap up there.
Thanks, Caleb. So Caleb really described the fact that opioid use disorders are a chronic relapsing medical condition, much like diabetes or hypertension. And he's absolutely right that people who tend to leave treatment sort of quickly or prematurely have relapse rates somewhere north of 90% within the next 12 months. So it's a very difficult condition to try to get under control simply using abstinence and social support. Many people do benefit by avoiding relapse when they are on medications that help them stabilize. So my short summary of why these medications work are, if I'm an active heroin user, I'm having to inject 3 or 4 times a day, and then I go into withdrawal, and when I'm in withdrawal, I'm looking for my next hit, and then I go back, and this is basically what my life is like, is a constant roller coaster, particularly when I wake up first thing in the morning. It's the withdrawal symptom that really drives a lot of the behaviors that many people are concerned about, petty crimes, stealing in order to support their habit and finding their next hit, etc. So the reason that these medications work, they are synthetic opioids, but they're very long-acting. So heroin has a half-life of about 4 to 6 hours, which is why people are using multiple times a day. Both methadone and buprenorphine have a half-life of 24 to 36 hours. So if you take it at the exact same time every day, you slowly build up the right blood level, and then you are literally, your brain chemistry has normalized. And our patients will say, with the help of this medication, that they do feel normal. And many of our patients are just striving for that. So over time, chasing the euphoria actually ebbs as tolerance builds, and people don't even feel that euphoria anymore. They are just going into withdrawal and trying to get out of that withdrawal syndrome. So the medications are incredibly effective. They're incredibly cost-effective as well. They cost about 1/10 of what it costs for somebody to go through the prison and jail system. We cannot arrest our way out of this. I think we have the full support of the Seattle Police Department and the Sheriff's Office and the Prosecuting Attorney's Office in this regard. We need to be trying some new solutions for this. So making treatment readily available and in locations where people can easily access it is the key to this epidemic. Caleb's project down with others down at the Public Health Department is the perfect place for it, because people, as they progress along the addiction pathway, very often do end up homeless because their brains have become so disordered. They've burned all the bridges with all the key people in their lives. They don't have any money left anymore. They don't have insurance. They don't have shelter, and they end up on the street trying to figure out how to maintain their habit while they're going through this horrible withdrawal syndrome. So helping people who have gone that far and getting back into control of their life is a huge challenge, and it happens. I know many of you were in the room were at our fundraiser last week, and we had a fabulous story of one of our patients who was brave enough to make his story public. I actually showed it here when I spoke 4 years ago. This is a young man who had been in and out of the jail system. He said, I've probably been in jail 30 times, and he shared his mugshots with us. So you saw him as one of the people that were displayed earlier. Many of us would have passed him on the street and gone, he's beyond help. This guy got into treatment. He cycled through a couple of times as he figured out that if he stayed in treatment, he wouldn't go back into relapse. So he got engaged in treatment with us, got stabilized on methadone, went on and became a cell biology technician. I mean, who would have thunk, right? Here's this guy living on the street, and part of the video, I love it, he pulls out this cell biology textbook, and you just go, ah! I mean, it's incredible. So we literally see people re-emerge physically as they come to our dispensary windows to take their medication. So it's very effective, it's very cost-effective, and it is the solution to helping people with the condition that, again, 75% of folks who are active drug users, they're not enjoying it, they are looking for help to get out of their condition. So our programs are, we have two different kinds of programs. One is with the medication Suboxone or buprenorphine you can get from your family doctor through a prescription. So if you're somewhat stable, you can succeed with just taking the medication and moving into recovery through that pathway. Others who have a greater condition have to enroll in our opioid treatment program, which allows us to dispense on a daily basis either methadone or buprenorphine to folks who also must engage in counseling. They're paired with a medical provider, and they give us at least monthly urine drug screens. So that's sort of the ICU of opioid use disorder treatment. So those are the two forms of medication-assisted treatment that are offered, and I think I will stop there so that we can open it up for some discussion.
Right, we're gonna open it up to Q&A here in just a few seconds. I just want to take a couple of nuggets and repeat from both of you, so people make sure that we know that there are drugs to treat this disease. There are effective drugs that can treat opioid use disorder. And you mentioned the methadone and buprenorphine and naltrexone. Also hear about Narcan. Have you heard about Narcan? Right, it's the overdose antidote. It usually comes in a spray form through the nostrils. And if somebody's in an overdose situation, you can spray it into their nostrils and they will revive. It's kind of miraculous. If you're already gone, though, of course you have to give it in a timely manner. And most people who die of overdose don't just suddenly keel over and they're dead. It's like a process of their breathing slowing down and they stop breathing. So we have drugs that work. We know that 79% of people that you interface with want treatment. So let's talk about stigma, because this is one of my biggest gripes. And when I talk about, well, why aren't there more treatment centers then? If this works and we have this crisis, and Molly can talk about the obstacles she's faced to trying to create more treatment centers, and Caleb can talk also about just the reluctance of people to recognize it as a disease. I think none of us would discriminate against anyone who has a brain tumor. Would you discriminate against somebody who had cardiac issues? Would you discriminate against somebody who has diabetes? No, we don't do that. We allow them to come into emergency rooms if they need to. If they need treatment, we don't tell them to come back in 3 months when we have a bed. So let's talk about the whole stigma part of it, which creates so many obstacles for these people to try to get well. Who wants to start? Molly?
I'm happy to start. Some of the stories that our patients relay, even when they're in treatment with us and stabilized, about family members or even some of the medical community can judge patients for the condition that they have. So it is really the single biggest problem that we have with being able to get more treatment options and locations open for people. It's very important that we check the language set that we use, so junkie, addict, and these are all incredibly pejorative and other language. So I've been on a campaign to help people use the term substance use disorder and opioid use disorder, which is the medical way of describing what this condition is, rather than labeling somebody as someone who should be kept at arm's length. It's very important. One of the best things that all of you can do is help talk about what you may have learned today with people who you know, your family members, your coworkers, because there is just a tremendous amount of misunderstanding of what we do. I often have people come up and talk to me like, how can you do the work that you do? Like, even when I first took this job, I was hesitant to tell people what I do for fear of how people would react to it. Fortunately, there's been a lot happening in the last few years that I think the tide is turning, but we're nowhere near where we need to be.
How about you, Caleb?
Yeah, I think to see how stigma gets manifest is that people feel stigmatized, they feel that shame, and they don't even initiate asking for help. They just stay isolated and alone. So that's sort of the first part of it. And then if they do get it together, get that big breath of confidence and ask for help, then a person rejecting them and saying, you just need to make better decisions. What are you doing? You're making these bad choices. You just need to make better choices. Why are you doing this bad stuff? And that's why your understanding around what opioid use disorder is, and that people may make an initial behavior or choice to use opioids. No one's signing up for opioid addiction, and you're not going to make that same choice just to get off. It's not as simple as a choice. And you now understand that. You know more than 99% of the general public. And you also know that medications support recovery. So I think we also have the stigma around medications, which is very important to understand. We have more than 20,000 people in our state on treatment medications. We probably need another 2 to 3 times that many on medications. And we're trying to set a foundation that'll last a couple of generations, because we're talking about young adults. So this issue on stigma is really important, and it's something that you can do just to educate, the next person you talk to about this. I learned about this. And I think each of those 3 websites we have up there, any of those can be sort of a portal to start a conversation. And I really encourage you to do that, because too many people are living in the shadows, and they're then dying in those shadows.
There's so many parents who, because I've been a little bit on the front lines on this issue, who will pull me aside at a cocktail party and be whispering about their son or daughter or a sister or brother or whatever. And it's like, still, the shame, I don't want anybody to know in my neighborhood that I have a child that's struggling with this. I don't want anybody to know that I'm struggling with this. So until we can, put the stigma away and use compassion towards what is a brain reward dysfunction, then we're going to continue to struggle to get help for people. So what do you think? Ken, you want to do some Q&A here? Yeah. So we'd love your questions.
I have a question as we're walking back here, Caleb. Has your facility on 4th and Blanchard been open long enough to develop any kind of outcome statistics?
So we're writing a paper right now, and I think what's really important about it is that program actually allows people to start who are continuing to use alcohol and methamphetamine. That is often something that will not allow people to get into treatment. So there are many treatment programs that say, well, we don't take people who are homeless, or we don't take people who use other drugs, and unfortunately, that's 80 to 90% of heroin users, which basically means we're going to be stuck. So what we're seeing is that a whole different range of people can stay engaged. And unlike research I actually did at Evergreen Treatment Services a decade ago, and with other programs where we actually used to have people leave treatment if they were continuing to use other substances, we're changing those policies to keep people engaged. And what we're finding out is that people may continue to use those other drugs, and they will stay on medications, and they will have the life-saving benefit, and they may eventually, many will then start tapering off those other substances as well. So we're engaging folks, we're engaging the right folks, we're engaging homeless people, and we're also showing that this model does work and engage the people who really need it.
Great. Before we take the first question, I just want to thank everybody in the club who donated to SRSF, because last fall we donated to Evergreen Center the defibrillators that they need in several locations.
Yes, thank you very much for that. It was hugely helpful, so thank you.
Right. Bert has a question.
You might have just answered this, but I was just wondering, I loved your visuals. The visual I wanted to see and didn't was the one that said the opioid categories and then the non-opioid categories. And so we keep hearing right now a lot of publicity about the opioid crisis, and I just like a quick explanation of some of the other categories and what, if they have similar issues or differences.
Yeah, so I apologize. You got the ABC, but maybe not the whole alphabet. I apologize for that. It is on the webpage, sort of our stopoverdose.org webpage. It's on the Alcohol and Drug Abuse Institute webpage. I think you have some basic information about what is opioid use disorder. So opioids are things that derive from opium, right, from the poppy plant. Heroin is made out of the poppy plant as well. So it's sort of it's a natural product that then has man-made processing. And we have pure synthetic opioids. And so the issue is, all these opioids, by definition, an opioid is something that binds to an opioid receptor and turns it on. The difference is whether it is long-acting or short-acting, if it's strong or it's weak. So those opioids are all different substitutes. So you could be using fentanyl, which is very short-acting and very potent, or you could be using methadone, which might last a day. So they're all binding these opiate receptors. They're all substitutes, but they work differently in terms of how strong they are, how long-lasting they are. And so a few of them are Vicodin, Percocet, OxyContin, Dilaudid. There's a long laundry list of them.
What about non-opioid drugs?
Methamphetamine.
Yeah, methamphetamine.
Sure. So we think of opioids are a classic narcotic, meaning causes sleep, right? There are other sedating substances. Alcohol is one of them. A very similar drug to alcohol are benzodiazepines, Valium and Xanax are very, very similar drugs. Very dangerous in combination. Those sedating drugs can really lead to overdose. And then there are a whole range of stimulant medications, things like Ritalin and amphetamine and Adderall and those things. And then there are some illicit forms of those like methamphetamine, which is a very potent stimulant. It actually is a prescription diet drug. I don't know if people realize that. So there's a reason that people use drugs. They fill some function. We need to remember that. It's not some crazy thing that people use in drugs. At that moment in time, they're getting more benefit than harm. And it's very true with stimulants as well. We have very widespread stimulant use among adolescents, among the military. They're getting used for a lot of different functions. And so the challenge we're talking about is, I'm not saying alcohol or drugs are intrinsically bad. Heroin used to be illegal. Alcohol used to be illegal. These are decisions we make. It's when people's use gets out of control and it's causing them harm. That's what we're really concerned about.
And can I just add one thing, that of all the drug overdoses, that the numbers that I put up there, 66% are opioid related. Okay, another question. We have our last question. I'm sorry.
Hi, I want to thank you guys. I had the privilege of taking the tour with Molly, and just to say how impactful that was, I'd encourage everybody in the club to take that offering, not at the same time, but I wanted to know what the, at the local or state or federal government, what is the conversation shifting and changing, and is that approach also being held in parallel?
There's a lot going on at both the federal and the state level right now. So we're lucky to live in a state that's really at the forefront of trying to rein in prescribing practices. So there are efforts underway and changes in the laws in order to, instead of giving somebody who had a tooth pulled 30 days worth of prescription opioids, a maximum of 7 days for a first-time script, and allow patients at the pharmacy window to say, I only want 2 days worth. I don't think I want all these in my medicine cabinet. So that's happening. There's significant expansion of places to dispose of opioids. So if you have any in your medicine cabinet right now, I encourage you to get on the King County website around drug take-back boxes. They are everywhere. There are hundreds of them in King County. So getting them out of your medicine cabinet is very important. Don't flush them down the toilet. You can mix them with cat litter and get them wet and throw them in the trash, but don't flush them down the toilet. So there's a number of things that are going on in the prevention area, in the treatment area, trying to expand access to care, and in some of the reimbursement realms as well. And also just there's a lot of education going on generally.
Great. I want to thank everyone for your attention and your compassion, and one sentence about what people can do to help this problem. First you, Caleb. Got to make it short, baby.
I already said it, but I just, talk to somebody. Talk to somebody today or this evening and just tell them something about what you just learned.
Molly.
Please come to our clinic and get a tour. It'll really be helpful for you to understand how this treatment works. So just contact me and I'm happy to set up some tours.
Right. Thank you, everyone. And we invite you to visit our websites to get more information. Thank you so much. Thank you.